Today I would like to talk about a very important aspect in the treatment of chronically ill patients, both psychiatric and somatic patients, that is the possibility of actually predicting treatment adherence using psychological measures. And specifically, I would like to talk to you about the results of our meta-analysis concerning the predictory role of affective temperaments in predicting treatment adherence in various population of patients. So let's start with understanding why the whole topic is important, that is, what is the problem we are facing. Our major problem is that we have problems concerning adherence to long-term medication regimes in general. Therapeutic adherence, especially in chronic somatic and psychiatric patients, in those patients who require long-term or continuous maintenance therapy, is pivotal to controlling the symptoms and to prevent recurrence, to influence the illness course, and to influence outcome, mainly to prevent a worse outcome in these patients. Thus, what we know is that therapeutic adherence in itself is a strong determinant of the success and the safety of using efficacious treatment and the long-term well-being of our patients. Adherence to treatment is very strongly also related to costs, to preventable healthcare costs stemming from relapses and recurrences, stemming also from repeated hospital admissions, stemming from disease course which is turning more chronic, and also stemming from the resulting decreased productivity what we see in these patients. So finding an actually pharmacological treatment which is actually effective and efficacious is only one component of our therapeutic success in case of these patients. What is also equally important and equally challenging is actually getting the patients to actively participate in their treatment in the form of adhering to their medical recommendations. It is actually estimated that almost 1/3 to 1/2 of the patients do not take their medications as prescribed, and this actually prompted the WHO to declare that medication adherence is actually as important as finding suitable medications for patients, and it also to declare that improving adherence would have a significantly greater impact on the general health of the population than improvement in specific pharmacological and other medical treatments. So now we know what the problem is. Let's see what the solution might be to this problem. How can we actually identify which patients are going to be adherent to medications? How can we improve their adherence to medications? We actually have to identify ways to predict which patients are likely to be adherent and non-adherent based on possibly psychological factors such as, for example, personality traits, temperamental traits, and behavior. Now, our team here has been investigated affective temperaments for a while. So the question naturally arises if affective temperaments can actually be used to predict medication adherence in different patient populations. And I'm sure some of you are very familiar with affective temperaments themselves. They are what we consider the relatively stable and strongly biological and genetically based cores of the personality. And because of this strong genetical and biological basis, they manifest quite early during the lifespan, quite early during development. And they are relatively stable throughout half-life. And they are characteristic of the general population, but they also predispose to affective disorders. They can actually be considered the subaffective and subclinical manifestations of the high-risk states in the road to development of affective disorders. We know 5 of these affective temperaments, each describing a different type of reactivity. We know the depressive, cyclothymic, irritable, anxious, and the hyperthymic affective temperaments. And what these affective temperaments actually do in our everyday behaviors, feelings, and conditions is that they account for our activity level, our moods, our rhythms, and they are also related to cognitions. The affective temperamental model has been actually developed by Professor Akiska, and this is based on a conceptualization which takes some of its roots from the Greek philosophy and psychological medicine, but also it is more strongly based on the observation of mood disorder patients and their healthy first-degree relatives. So what may be the clinical importance of using affective temperaments in our practice? Affective temperaments themselves are not pathological conditions. They do not have a pathological value in themselves, but they represent vulnerability towards a variety of important factors, as I have mentioned previously, towards mood and other psychiatric disorders, and they also are strongly associated, based on several very well conducted studies, with several somatic conditions, including cardiovascular disorders, disorders such as hypotonia, stroke, recovery after stroke. They are also related to obesity, diabetes, chronic infections such as HIV. And they also, besides being associated with the development of different types of disorder, may also affect the long-term course and treatment outcome of these conditions, because, as I have just mentioned, they have an influence of emotions, conditions, as well as behaviors. Now, affective temperaments and illness scores may also be related, because affective temperaments may actually be associated with complying with treatment recommendations in the behaviors which are associated with complying with treatment recommendations. So what do we know so far about affective temperaments and treatment adherence? So far we have a number of studies which suggest that affective temperaments may indeed predict treatment adherence. Why they are clinically potentially important is that they are relatively can be easily assessed by using a self-administered and not so long clinical scale, which is a temperamental evaluation of Memphis, Pisa, Paris, and San Diego. This is a 110-item auto questionnaire which can be quite easily filled out by any patient. And if we administer these instruments to a number of patients, then what we hope is that we can be able to identify such high-risk subgroups within our patient populations for which clinical treatment adherence may be critical. And thus, this knowledge, understanding their temperamental constellations, may be yielding out us the possibility to inform the treatment plan, may empower us to aid the personalization of our medication approach, and thus may help us to enhance the cost effectiveness of our interventions. Now, there have been a number, not such a big number, but a number of affective temperament studies dealing with adherence, but they have several shortcomings. Although we know that clinical and public health burden is associated with treatment non-adherence, most of the available studies which document the association between treatment adherence and affective temperaments have a few number of problems, mainly low statistical power, small representativeness of the samples, using inhomogeneous ratings, not the same ratings for the same outcomes. However, if we conduct a meta-analysis, then these shortcomings can effectively be addressed, and this approach may provide us with an overall effect estimation from pooling low statistical original studies. So this is actually what we set out to do. We set out to conduct a systematic review of the available studies on affective temperaments, and then we did a meta-analysis on our findings. Now, this is just the design of our systematic review. We used specific research terms, TEMPS-A and adherence and compliance. We searched the usual databases, and eligible studies were those which measured affective temperaments using the TEMPS-A, which measured adherence by any of the accepted and validated methods, and which evaluated the relationship of these two variables using any statistical method. Actually, what we could find was only 9 studies involving more than 1,100 patients. These studies were investigated both psychiatric and non-psychiatric populations. As I have mentioned, they all measured affective temperaments using the TEMPS-A. For medication adherence, a number of scales were used, 5 different scales which have been specifically developed and well standardized and validated to capture adherence with pharmacological treatments, and they used statistics either focusing on correlations or establishing the main difference between the two groups. Now, after these findings, after identifying these 9 studies with an acceptable methodology for our meta-analysis, we actually conducted the meta-analysis with the goal of comparing affective temperament scores in the two groups, in adherent and non-adherent subjects, of course with the hypothesis that there will be at least some of the TEMPS-A scores, some of the affective temperament scores, which are going to be significantly different between these two groups. And we used the random effects model, and we estimated the effect size using the standardized mean differences. Now, what we have found was actually what we expected, that some of the affective temperaments were significantly different between adherent and non-adherent subjects, namely cyclothymic, irritable, and depressive affective temperament scores were significantly higher in those subjects, in those patients who were non-adherent to the prescribed medication regime. So this is our findings. Our findings are very simple. However, our findings are going to be important if we have a translational approach and we can actually put them to some kind of a clinical use. So what did we find which we could actually exploit in the clinical field? We have found, as I have just mentioned, strong association and adverse association in case of a 3 affective temperamental score and medication adherence, which results suggest that these affective temperamental types may be able to actually predict decreased therapeutic adherence and thus may be able to predict treatment outcome. So what does this mean? This means that the TEMPS A scale in the clinical field to actually contribute to the identification of high-risk groups who are high risk for non-adherence. They could also be used to predict the success of our planned treatments, and they could also be employed in the personalization of our treatment plans. And in the end, they could maximize the success of both costly and burdensome interventions. So they could be actually very important in our clinical field. Now, okay, affective temperaments, several of them are actually strongly associated with treatment adherence, but how do affective temperaments actually do it? How are they related to treatment adherence and possibly treatment outcomes? Several of these affective temperaments may be involved in less favorable reactions towards disturbing events, for example, cyclothymic and irritable temperaments. Specifically, cyclothymic temperament seems to be very important. Maybe you remember I have mentioned that cyclothymic temperamental scores are also higher in case of treatment non-adherent patients. They are associated with an intolerance of subjective suffering. They are associated with a tendency for enhanced emotional response upon stressful experience, and it is also associated with increased hopelessness scores. So what this means, the cyclothymic temperaments and to some extent the other 2 temperaments which also showed an adverse association with treatment adherence, that is irritable and depressive temperament, may make it more difficult for our patients to tolerate several factors which are associated with long-term or even lifelong medication treatment. So it may be more difficult for those who possess a higher ratio of these affective temperaments to tolerate the burden of actually having to take medications on the long term or all their lives. They also may have an increased difficulty to accept the unchangeable fact of illness because they do not tolerate subjective suffering. They also may have an increased difficulty to tolerate the fact that sustained or even lifelong adherence may be required towards a medication regime, and also they may have an increased difficulty in accepting or tolerating the side effects coming from these medication regimes. Okay, so now we understand how affective temperaments may actually be associated with treatment adherence. We may have some kind of a view what may mediate this relationship, what behaviors, what emotions, and what cognitions may mediate this relationship between affective temperaments and treatment adherence. But we only have a couple of cross-sectional studies, in fact, a few long-term studies, and we only have 1 meta-analysis, and I have mentioned individual studies are hampered by a number of shortcomings. So we need further studies. We need to see what's next then, because as I have mentioned, it is imminent to improve the adherence in our patient populations. And for this, we need to be able to identify those patient populations who are at a higher risk of treatment on adherence. And our results suggest that affective temperaments may be one of the important tools. But of course, we need to test what we found. So first of all, we need to understand in a more depth how the core of personality, such as, for example, affective temperaments, actually influence medication-related beliefs, cognitions, attitudes, emotions, and behaviors. So we need specific studies for that. And then if we understand this and if we tested affective temperaments and also other personality, behavior, and emotional measures, we need to be able to use them to develop patient-tailored and personalized education programs, support programs, and psychotherapeutic intervention methods. Because actually the temperamental makeup of the patients and the majority of the personality makeup of the patients is not going to be changeable, and if it's going to be changeable by long-term psychotherapeutic intervention methods, it is going to be taking a long time, in case several times it is going to be taking years. So we have to actually develop a multi-level approach to using our study results. So we have to develop different levels of intervention in case of these patients, from simple education to psychological support to psychotherapeutic interventions, with the aim of targeting the personality obstacles of adhering to medical recommendations, and with the aim of increasing the active participation of the patients in their successful treatments. So for this, we first of all need to understand in a very detailed ways how these personality and temperamental factors are involved in behaviors, feeling and cognitions in the background of adherence and non-adherence. Beyond this, we should aim at also to understand how the genetic background and how the socio-economic contributors and environmental contributors are involved in the development of temperaments, and how they are involved in the relationship between temperaments and later on medication adherence, because then on the long term, not only via psychological measures and psychological testing, but potentially also by genetic testing, we could at a very high efficiency rate screen for those patients in the first encounters who are likely not to be able to adhere to their medication treatment without some kind of support, some kind of an education, or some kind of a psychotherapeutic intervention. This is all I wanted to say. Our study was just the first step. We are planning several more research, several more studies on understanding in long-term studies the relationship and the effect of affective temperaments on treatment adherence, and also in understanding how they could be exploited to increase treatment adherence on our patients. I hope you have found our studies interesting, and I would like to thank you for your attention today.